I would challenge you, if you do this ultrasound biopsy, again, the example I bring, what if you missed that tumor cell that was just near to your needle that you biopsied? When I take those biopsies, this is what I tell my patients. We may be reassured, but we may not be correct. Now, what makes me sleep at night, even when I say that admittedly to my patient, is that I know that I can offer curative intent, that if I follow them very closely, I did not miss a window. One would arguably say that I mentioned like the 13% distal metastasis, because that's what kills our patients, is liver mets. I mean, it's the, distal metastasis. 13% will be developed even without complete clinical response, that very flat scar. But even if I offered somebody a TME after TNT, they still have a 10 to 15% chance of developing a liver met later on. So these are the numbers that make me less tachycardic, as I say, that we try our best and we'll follow you very closely. I tend to be less risk averse than other colorectal surgeons, in my institution. But I think with that, I feel pretty comfortable to continue. And then define what your surveillance criteria is. If you think you have a partial responder, you saw I did not follow the guidelines of our institution, I brought them back much sooner.
If I may comment on that also, I think it's important as a multidisciplinary tumor board that we really set what are the priorities. Priority number one is that we save the patient. And organ preservation is important, and organ preservation is an important tool that we need to pursue nowadays. And we feel very comfortable with it, but we will, if we go too far in that direction, lose patients. So I think we need to agree on each patient, this is the right approach, whether it's some endoluminal treatment or whether it's a more radical surgery. And if we obviously do more radical surgery, we'll have patients that will have occasionally a negative or a pathological complete response, so no cancer actually visible, even though we thought it wasn't a complete response. But we always will be between those two, but we should have the main goal to save the patient.
I just want to give him the gastroenterologist answer. If you're wondering if you're at the cecum, you're not at the cecum. But I think if you're asking, is this a complete clinical response or is not a complete clinical response, would you agree? Is it's a flat, complete scar with nothing that's abnormal. Digital rectal exam is normal. And the other is normal, that's a complete clinical response.
That's a complete response, yeah.
Yeah, full disclosure, I am colorectal as well, so we shouldn't be all talking, but I totally agree with you. I think it's very subjective, this grading system, but so is MRI as well. Like there in MRI, there's MRTRG, and actually like 5 categories, and MRTRG 1 and 2, these are what we consider complete response. If it's 3, 4, 5, we get nervous. So 1 and 2 we monitor. But same thing applies in endoscopic view as well. It's 4 grading, no response, partial, near complete and complete. So actually it's similar to MRI, it's not very different. It's also subjective. MRI is subjective, this one is subjective, but combined together these, pretty accurate, and we did this, and we'll talk about that a little bit tomorrow. The sensitivity and specificity goes up when you combine these two, and it's pretty accurate. But the key is, I think, same people monitor this in terms of endoscopy. Who diagnosed this? Initially, you need to document, take a picture in the system, and then every 3 months, within 2 years, also monitoring. And they need to be in the electronic medical record system and documented and photographed. The issue is, unfortunately, not all of us, many surgeons that follow these patients have endoscopy in the offices. So that where it becomes a little bit iffy and like very unreliable to monitor these patients. We really need to make all the efforts to have endoscopy in our offices so we can really accurately monitor them, and continuity, always the same person. ESD after TNT is a significant role, and we have done probably more than Memorial, because their data is after chemoradiation, not necessarily after TNT. but there's certainly some of the time what is mentioned, the near complete responders, some adenoma tissue, not necessarily what is shown like that exudate or ulcer, because that's not something that you can treat really with ESD or local excision. You gotta wait there to see what the end result is, but like in your first case, it end up being residual tumor there. But sometimes, and I'll show some of the videos tomorrow for that, there's some adenoma tissue left behind, but according to the protocols in NCCN, you really need to do TME. But really, there might be some role to give these patients an opportunity of organ preservation. And in our series, we have done more than 20 as such cases, and our organ preservation was 70%. So in other words, majority of these patients we did not find beyond high-grade dysplasia. But of course, if you find after local excision with ESD a tumor or cancer, then we proceeded with TME. Even in some of these patients, we didn't find any more residual, because these regrowths or residual disease is only in the submucosa, and if you have clear margins, you can even treat them that way. Why not to do the local excision? We know that the wound healing and large scar then is really very painful for these patients after chemoradiation, one reason, and second is if you end up doing TME afterwards, you violate all these planes and your TME plane is incomplete, so you are kind of cutting the branch you are sitting on for future if you need to. But certainly ESD after TNT has a huge role.
I agree. Thank you.
One more question.
Stephen from MD Anderson. Just, obviously the MSI is such a great biomarker for organ preservation. For MSS, there's some data, seems like that in patients who are undergoing organ, watchful waiting after TNT, seems like it does increase potentially disseminated disease, potentially. Right? So, are there selection markers? I mean, thinking like biomarkers where for sure the patient's going to respond with they'll be successful for surveillance versus a patient that you need to potentially to do upfront surgery after TNT. Any research in that area for rectal cancer?
Who wants to take that one up?
I hear what you're saying. I think the problem is how do you match those patients who recur after a complete clinical response to the patient population that you would have resected anyway to make that conclusion. So if you are going to say complete clinical response has a worse prognosis than complete path response, sure. But that's not an appropriate control to compare to, and I think there were some publications trying to compare it that way. And of course, you're going to have a worse outcome. I don't think in the literature there's really a convincing evidence that watchful waiting is harmful at this point. I do know that there was a publication that made a buzz about 5-6 years ago, but I think it has that kind of bias of what you compare to. And unless you do a good randomized study, you're not going to be able to answer this question. And if you do the randomized study, you're going to have to look at the overall population and the strategy per se, not really read out the patients who had a CCR and then perhaps develop metastatic disease. Maybe those patients were never a complete path response. So I think that's the challenge.
Well, thank you for the panel. Excellent session.